Hi, my name is Ren José Quijije, and today I'm going to talk about linear IgA bullous dermatosis. Um, First, we're going to talk about the definition of this disease. Okay, it is also known as linear IgA disease. It is a rare idiopathic or drug-induced autoimmune blistering disease characterized by the linear deposition of IgA at the dermoepidermal junction.
Linear IgA bullous dermatosis. Autoimmune disease characterized by subepidermal blisters and linear deposition of autoantibodies at the dermoepidermal junction. The accumulated autoantibodies are of immunoglobulin A and occasionally immunoglobulin G classes against epidermal basement membrane proteins. The dermatosis is sometimes associated with malignancies and use of certain drugs, for example, vancomycin.
Now, issue applied in Ecuador. There are several cases in Ecuador, but they are characterized by a previous disease, systemic lupus erythematosus.
Immune disease. 2. Linear immunoglobulin A dermatosis. And welcome to the Learn Dermatology video tutorial series from darkskindermatology.com. Our topic for today is 10 facts about linear immunoglobulin A dermatosis. 1. Linear immunoglobulin A dermatosis, LAD, is an autoimmune disease. 2. Linear immunoglobulin A dermatosis was formerly known as chronic bullous disease of childhood. 3. The age of onset for this immunobullous disease in children is around 4 years. 4. The age of onset for adult linear immunoglobulin dermatosis ranges from the teen years to the 80s. 5. Linear immunoglobulin A dermatosis can be caused by antibiotics such as vancomycin. 6. Other drugs which have been associated with linear immunoglobulin A dermatosis include amiodarone, captopril, and carbamazepine. 7. Linear immunoglobulin A dermatosis can also be idiopathic. 8. These multiple causes of linear immunoglobulin A dermatosis result in deposition of immunoglobulin A antibodies in the basement membrane zone. 9. The antibody deposition results in activation of the complement system and neutrophil chemostasis. 10. This leads to the formation of blisters as the cells in the dermis and epidermis separate. That's it for today. To learn more about skin, hair, and nail diseases and see color pictures of each condition, visit darkskindermatology.com today.
Okay, pros and cons. The clinical features of this disorder can be difficult to distinguish from dermatitis herpetiformis, another autoimmune blistering disease. The distinct immunopathic findings in lab and the absence of an associated gluten-sensitive enteropathic confirm the status of LAIVD as a distinct disease. Adults frequently develop LAVD in the later stage of their lives, with many cases occurring after the age of 16. In children, the disease usually presents between the age of 6 months and 10 years. In a series of 25 affected children, the average age of onset was 4.5 years. Rarely, neonates are affected.
Hello, I'm Chika Ohata, Associate Professor in the Department of Dermatology at Kurume University School of Medicine. Our department has performed substantial research on autoimmune bullous diseases for over 15 years. I was the principal investigator for the study on linear IgA bullous dermatosis, LABD, without linear immunoglobulin deposition other than IgA at the basement membrane zone in direct immunofluorescence. We did a study because we noticed that LABD lacks common diagnostic criteria. In fact, some investigators believe that exclusive linear IgA deposition with no other immunoglobulins or complement deposition at BMZ in DIF is mandatory, whereas others believe that concurrent weak IgG deposition at BMZ in DIF can occur. However, in the latter scenario, patients may be diagnosed with bullous pemphigoid, linear IgA-IgG bullous dermatosis, or epidermolysis bullosa acquisita. Therefore, we thought it was important to study clinical manifestations and serological findings in patients with subepidermal blisters with only IgA deposition at BMZ in DIF. We retrospectively collected data for 101 patients who met these criteria and excluded patients who showed linear IgG and/or IgM deposition at BMZ in DIF. This study confirms the heterogeneity of autoantigens in LABD. Among the 101 patients, 54 had IgG anti-BMZ antibodies detected by either indirect immunofluorescence, immunoblotting, or enzyme-linked immunosorbent assays. No statistical differences in clinical manifestations were found between the IgG antibody possessing group and the remaining group. Approximately 50% of this cohort exclusively had IgA autoantibodies, and the diagnosis of LABD is clear. However, the diagnosis of the remaining half cohort may be complicated. These patients could be diagnosed with linear IgA-IgG bullous dermatosis or simply LABD. If these patients are diagnosed with LABD, then consistency might dictate that patients with linear IgA and concurrent weak IgG deposition in BMZ in DIF should be diagnosed with LABD. We still do not have the complete answer to this perplexing diagnostic question. Consensus for LABD diagnostic criteria is urgently desired, even though it may be arbitrary. Thank you.
Now, applications in medicine. Children classically present with white-cross annular blistering that exhibits a predilection for the lower abdomen, thighs, and groin. In adults, annular lesions are less common, and the extensor extremities, face, and trunk are frequently affected. Mucosal lesions manifesting as inflammation, erosion, or scarring may also occur in patients with LABD. Linear IgA bullous dermatosis is a rare disorder. Reports of disease incidence from various countries have ranged from less than 0.5 to 10.3 cases per million individuals per year. A predilection for LAVT based upon ethnicity or sex has not been definitely established.
Linear IgA bullous dermatosis. It is one of the subepidermal vesiculation, and we may see neutrophils as the main inflammatory cells. And there is sometimes a scattered eosinophils and perivascular lymphocytic infiltrate. Direct immunofluorescence will show that linear deposition, which is the most important thing here, is the linear deposition of IgA at the dermo-epidermal junction, and that is usually 80% of the time. So linear IgA is heterogeneous subepidermal vesicular disorder. In children, the disease is referred as chronic bullous dermatosis of childhood, and both disorders caused by autoantibodies against the protein 97-120 kilodalton as degradation product of bullous pemphigoid antigen 2. Classic disease results in a group of annular lesions with thin spaldy, it's also important, and that we call it string of pearls. Drug-induced cases have been described using vancomycin. So we see here it is subepidermal vesiculation, and we see collection of neutrophil. This is a low power collection of the neutrophil, and sometimes some peripheral lymphocytes in the subepidermis and eosinophils. And when we do direct immunofluorescence, we'll be showing the linear deposition of IgA. Histologically, as you know, that there is significant overlap with dermatitis herpetiform, but we see here it is linear by using direct immunofluorescence, so you have to do the direct immunofluorescence differentiate between them. This is a good picture for the IgA deposition, IgA dermatosis, bullous dermatosis, and obviously here we see linear deposition in comparison to what we see ragged deposition in the dermatitis herpetiform. The next entity is the bullous lupus erythematosus. It is subepidermal bulla with the neutrophils and immunoreactant to the floor with salt split skin, and we see other features of the lupus erythematosus. The last entity for subepidermal blistering or vesicular bullous disorder, the friction blister, where we see it is usually mid-epidermal necrosis, and we see serum may be presented to this friction. If somebody is using labor, hand with hammer or something, you'll see this friction blister, and it is not autoimmune related disease.
Conclusion. This autoimmune blistering disease can occur in children and adults. The perioral and perianal areas may be more commonly affected in children than in adults. With high potential topical glucocorticoid treatment, the patient's lesions healed within 2 weeks, with no recurrence.
Linear IgA dermatosis and chronic bullous disease of childhood. Linear IgA disease typically occurs after puberty, with the majority of cases presenting after the age of 40. Chronic bullous disease of childhood usually presents before the age of 5. Both have a slight female predominance. Patients with linear IgA dermatosis present with pruritic, annular, or group papules, vesicles, or bulli distributed symmetrically on extensor surfaces. The clinical presentation may be indistinguishable from that of dermatitis herpetiformis. Patients may also present with lesions that appear similar to those found on bullous pemphigoid or epidermolysis bullosa acquisita. Oral and conjunctival surfaces may be involved, resembling cicatricial pemphigoid. Rarely, systemic symptoms such as fever, arthritis, arthralgias, and malaise may occur. This disorder has been associated with the intake of many drugs, including vancomycin, lithium, and diclofenac. These patients also demonstrate a small increased risk of lymphoid malignancy. In chronic bullous disease of childhood, young patients present with clustered, tense bulli, often on an inflammatory base, giving a cluster of jewels appearance. Lesions are typically located in the perineum and perioral region. New lesions may appear around the periphery of previous lesions, giving the appearance of a collarette of blisters. The sensation of pruritus or burning is common. For both disorders, blister formation is either within the lamina lucida or in the sublamina densa. On histopathologic exam, one finds subepidermal bulli with neutrophils along the basement membrane and at the papillary tips. Direct immunofluorescence demonstrates linear IgA, and indirect immunofluorescence is typically positive for low titer circulating IgA antibodies. On salt split skin, linear IgA deposits may be located in the lamina lucida, similar to bullous pemphigoid, at and below the lamina densa, similar to epidermolysis bullosa acquisita, or in both locations. Both diseases are acquired autoimmune disorders that occur secondary to the formation of IgA antibodies that interact with a number of different antigenic targets. Circulating IgA antibodies that bind the epidermal side of salt split skin typically bind to a 97 to 120 kilodalton antigen that is identical to a portion of the extracellular domain of bullous pemphigoid antigen 2. Circulating IgA antibodies that bind the dermal side of salt split skin typically bind to the epidermolysis bullosa acquisita antigen type 7 collagen. There are also patients with a clinical presentation similar to cicatricial pemphigoid. These patients typically have IgA antibodies that bind to a 45 kilodalton antigen on the epidermal side of the basement membrane. The course of linear IgA dermatosis is unpredictable, but most have disease that is present for years. Remission is unlikely. In contrast, chronic bullous disease of childhood is often a self-limited disease, with remission occurring within 2 years of disease onset.
Thank you.